So for those of you who don't know me, my name's Yanina, and I'm one of the ID pharmacists over at Moffitt Cancer Center. And our discussion for today, we're going to talk a little bit about bone and joint infections, minus any prosthetic joint infections, only because that's a whole topic of its own. Um, so we'll go ahead and get started. So I'd like to start off with this, right? Just so we all have a good time. So I'll have to do some x-rays to be sure, but I'm guessing you dislocated your shoulder, right? So I'm talking about imaging, and there's just a lot of diagnostic tests that we do for certain bone and joint infections. So the objectives for today are going to be to define and differentiate between bone and joint infections. What is osteomyelitis, septic arthritis? We're not going to talk about prosthetic joint infections. I originally had this as part of the lecture, and I just felt like it was a little overwhelming. Um, Look at the pathophysiology and diagnosis, and we'll talk definitely a little about antimicrobials and some of the literature, things that are in the literatures and things that have been, posted to us about oral antibiotics versus IV, and so a little bit of that. So I'd like to start off. This is for those days, right, when you need unicorns and rainbows. And I kind of put this in here only because bone and joint infections really are an extremely diverse set of infections, right? So it could be anything from osteomyelitis, which can further be then subdivided, right? Whether it's hematogenous, contiguous, or due to vascular insufficiency. You could be talking about septic arthritis, again, whether it's bacterial or non-bacterial, right? Whether it's gonococcal or non-gonococcal, whether it's of native joint or not. So again, it's a big spectrum or wide spectrum of infections. That's why we need to make sure that we kind of understand why they're different. Right. Just a brief overview, and I'm sure many of you already know these definitions, but again, just to as a refresher. So osteomyelitis, right, it's an infection of the bone. Um, when we talk about onset, acute versus chronic, so anything that's present for less than 6 weeks is going to be considered acute osteomyelitis. Anything that's present for more than 6 weeks is going to be considered a chronic osteomyelitis. And I want you to keep this in mind only because when we're talking about treatment, right? If you've had an infection for more than 6 weeks, if you're not acutely ill, chances are it's not an immediate emergency, right? So when we discuss treatment and why we use it, so in certain cases we do empiric therapy and in others don't, just keep this in mind. Just a refresher. I know we all know our anatomy, but just this is just a bone, and then you have your, you have the cartridge there. So again, this is more of an FYI than anything else. Okay. Now, when we're talking about septic arthritis, right, this is basically inflammation in a joint secondary to infection of the synovial fluid or periarticular tissue. Even though I'm not going to talk about prosthetic joint infections for the most part, I do want to talk a little bit about this definition. So prosthetic joint infection, it's, you've had joint surgery, and there's a nice lecture on this at recent Infectious Disease Society of America OID Week meeting, really talking about that not all joints are the same. Wrists and knees and hips, they're not the same. But in terms of timing of when you get the infection from the time of surgery is actually important. And any guesses as to why it's important? Like, why do I care if you got your infection at 5 months after surgery versus 2 months after surgery? So, well, treatment because of why, right? So the organisms you're expecting will be different. So early onset, chances are these are your virulent organisms that you introduce during the surgical procedure, right? Late onset actually looks a lot like early onset. It's not surgery introduced virulent organisms, but again, it's virulent organisms that you got subsequently, you're a year out, but it tends to have the same bugs. Delayed onset, it's that neither here nor there period. Tends to be, again, organisms you introduced in the OR, but you're less virulent organisms. So things like co-negative staph, for example. So it's very important to keep in mind. And knowing the onset will also help you to decide how you're going to treat in terms of can you retain the prosthesis, right? Is it, has it been long enough that it's probably going to have to come out, or is it like a fresh, brand new joint that you're going to try to save? Right. And again, this is more as a reference slide, but there's tons of different types of prosthetic joints, and then there's your native joint. Right. I like patient cases, so we'll go through the first one, right? Because this is, you guys are seeing patients. So you have a 40-year-old male who presents to the emergency room. Basically complains of back pain and fever. He does have a history of intravenous drug use. It's not really a history since it only happened 8 hours ago, so he's actively an intravenous drug user. His vitals, he's febrile at 39 degrees Celsius. His blood pressure is 110/55. His tachycardic and tachypnic. And a fantastic physical exam that we do, we find that he has a 3 out of 6 systolic murmur. He has tenderness over thoracic spine and percussion. So the ER goes ahead, blood cultures are drawn, empiric antibiotics are started. So when you're looking at a patient, this is what as we discussed, these are the things that we want to look at. What are some things that are going through your mind as a diagnosis in this patient? Which organisms, what antibiotics, and what imaging, if any, do you want to get, right? Sure. Excellent. So we'll go through all of these pieces and then we'll kind of wrap it all up. So, how you classify osteomyelitis? We talked about acute and chronic, but I think the route of infection is also really important, right? Whether it's hematogenous or contiguous. So, what do you think in adults? What do you think is the most common? Think it's hematogenous or the non-hematogenous osteomyelitis? Right. So, um, hematogenous osteomyelitis is really a problem in our little munchkins, right? It's more of a pediatrics issue. Um, about, well, we'll get to the actual numbers, but most of the time it's acute, right? You have a bacteremic event, you go ahead, there's seeding of a bone, and that becomes the result of the osteo. You can see some chronic osteomyelitis due to hematogenous spread, but it's more with organisms like mycobacteria, right? For example, you could still get it because it's disseminated, but it's not the acuity is not there. All right. So, munchkins, right? So, really a problem in pediatrics, especially their bones are still growing, right? So that's why a lot of the data that you see about transitioning to outpatient care or using oral antibiotics is actually in pediatric population. But about 20% of, in general, of adult cases of osteo are going to be due to hematogenous spread. And of course, as you said, the most common cause will be vertebral osteomyelitis. Usually, as that's the most common site. All right, now we said vertebral osteomyelitis is going to be the most common site, but even that, accounts for about 5% of all the osteomyelitis cases in general. And one thing to remember, it may present with or without an epidural abscess, right, in these patients. So it's really important to make sure you have not just the antibiotics, but source control as well. And lumbar spine does tend to be the most common area that it presents. Not surprising, your associating factors, the risk factors are intravenous drug users, right? Patients who are on hemodialysis and you're immunocompromised. Now, contiguous focus, it's actually, you want to look at it almost like two separate entities. Yes, it could be acute, and yes, it could be chronic. Basically, what you're doing, you're directly introducing the organism right into the bone, right? In young adults, it tends to be a result of trauma or surgery, let's say car accident, and the door goes right through the foot, and there you go, you get your osteo. In elderly patients, it tends to be more of a first as a cellulitis or pressure ulcer, and then a subsequent introduction of the organism to the bone. And we kind of discussed this a little already, but again, associating factors would be surgery, open fractures, the cubes in your elderly and burn patients as well. Now, vascular insufficiency, that tends to be predominantly a chronic type of picture. Basically, you have no blood supply going to the area. So the whole idea when try to use antibiotics in these patients, we always want to ask, can they get revascularization? Because if there's no blood supply there, it doesn't matter how much antibiotics you're going to give them. Usually diabetics, right? Or anyone that has some other peripheral neuropathy issues. Just talking a little bit about diabetic foot infections, because I'm sure you see none of that here in your institution at all. um, Wounds that extend to the bone or joint, of course, are going to be risk factors, previous history of wounds, and recurrent or multiple wounds. Now, I know we love imaging and we rely heavily on imaging, but if you're not in an area where you can readily get, an MRI, or for example, where it's a small bones are a little more difficult, and just something to keep in mind. Ulcers that are big, deep, right, and those that have a higher ESR, CRP, and positive probe to bone test, right? That's when your bone is exposed. All are most likely consistent with osteomyelitis. So you may not need that $1,000 test to tell you that if somebody's foot does that's consistent with osteo. It was very interesting discussion again at ID Week that with the instruments that you use to do this test actually were originally validated with metal blunt objects, which I was not aware. So I thought that was kind of, interesting. But so a little bit just looking side by side, right? I'm a visual. Yeah, right. That might have been my that. Yes, that'd be the recurrent.
So that's the tip of the swab
hmm
exiting. Yeah, that's hopefully we
The,
don't see too many of those cases per year.
so I'm a visual individual, so I like to look at things side by side, and I think this is a nice summary of acute versus chronic osteomyelitis and presentations. Again, your patients who present with acute osteo are going to look sicker, right? It's an event that happened within the last 6 weeks. Patients who have chronic osteomyelitis, they're usually not septic. They've been walking around with this for a while, right? So again, something to keep in mind. Questions, comments, concerns, maybe? Okay. And again, this is kind of the pathophysiology, or the steps that kind of the bone goes through before it goes from acute to chronic, right? And this again is a nice visual as to why acute osteo is easier to treat than chronic, right? Because by the time you get to the bottom portion, you see how there's already new bone formation, right? So anytime there's new bone formation and then there's a dead bone inside, at that time, this is what basically characterizes it as chronic osteo. It gets really hard to get antibiotics in there or any other treatment, right? So when you're in the acute phase, there's still blood supply going, to the area of the infection. So. All right, talking about diagnostics, my favorite thing is when people swab superficial wounds. And I think if we get nothing out of this lecture today, I'm going to keep on saying that this is really not diagnostic or a good technique to do. So what you need is actually a bone biopsy, which is your gold standard. You ideally want to do it at least 2 to 3 days off antibiotics, if possible. But and of course your histopath findings. I do know there is a study looking at specifically culturing the the sinus tracking and showing that if you do two of those cultures and they result in the same organism that actually is highly consistent of the same organism that's likely causing the osteo. Again, in general, though, we do not recommend culturing anything superficial, and many labs will actually reject any superficial swabs, or, as something to culture or work up. So, how do you do it here, Dr. Ayler? Anything that they would reject, or they're okay with this?
I think they reject that. They leave it more to the buyer. But, I think the nice thing about our institution is we have really good support from the dietary
Mm.
here. They tend to obtain cultures the right way. But that being said, if you see an individual diabetic patient with a pedal ulcer and the cultures grow Enterobacteriaceae like E. coli or Klebsiella and Enterococcus, you got to be thinking about where gravity takes stuff, right? So you're going to get contamination of superficial wounds on the foot with basically enteric bacteria just because of physiology. So
Let's see. Um, the other tests that we can order, right, are ESR and CRP, but again, non-specific. They may not be elevated, especially if you have a small bone. You may have a leukocytosis. You may not have a leukocytosis. Elderly patients don't tend to have don't tend to mount the same type of white count as younger patients. But what it is nice or not nice from a diagnostic standpoint, so about half of your patients will have positive blood cultures, and if they do, you can actually assume the organism that is in the blood is what's causing the infection, so you don't have to do the invasive procedures unless they're not clinically responding, and then you just have to go back and see if there's anything else. All right, treatment. As we all know, there are no guidelines for just osteo, right? The most recent set of guidelines that came out from Infectious Disease Society of America is on vertebral osteomyelitis, and we'll talk a little bit about those. There's definitely guidelines of prosthetic joint infections, diabetic foot infections, so most of the data is just extrapolated, into those. I was surprised how not easy it was to find some of the data on these things. Traditionally or historically, we use IV antibiotics for treatment, right? And usually 4 to 6 weeks. And I'm going to just open this up and just ask, do you know where the recommendations or the year or how we came up with this whole prolonged IV antibiotics? You want to try to guess what year the study is from that this has been based on? Okay, so 1970. So 1970, there was a study that was done using high-dose IV penicillin. Basically, the conclusion of the authors was that we have to use parenteral antibiotics, and it has to be a prolonged course of at least 6 weeks. I cannot recall if the debridement was done in any of those patients. I'm old. I'm not that old, but so. Again, so it's always nice to go and reassess why do we do things. Where's the data coming from? So I went and I just decided to do a little bit of a literature review. Some of these things you are maybe familiar with already, so just bear with me. So this was published in CID in 2012, and I don't know if you saw this review, and it was actually got a chance to meet the authors on this paper, and we had a very nice discussion about this. So looking at systemic antibiotic therapy for chronic osteomyelitis in adults. And so what they did was they took every study after 1970 from that landmark trial, right, that said IV long term, so anything after that, and tried to answer these 4 questions, right? In adult patients with chronic osteomyelitis, is there any antibiotic that's better? Are oral regimens okay? For how long should be given? And is surgical debridement always necessary, right? So those were the questions that they tried to answer. I'm a pharmacist, so we're going to have to talk about this a little bit, right? In terms of pharmacology, IV antibiotics, so beta-lactams, they get excellent plasma concentration, but their bone penetration or concentration of bone is anywhere from 5 to 20% depending on the beta-lactam. However, because you get such high concentrations in the blood, it is enough for that to cover the organism in the bone, right? Because of you overcoming the MICs. Vancomycin and daptomycin, no different than the beta lactams, right? They do not have good penetration into the bone, right? We use them because the concentrations, again, in the blood are so high that that ratio is enough. Because oral beta lactams get only about 10% of what of plasma concentrations as IV, they're not ideal agents for using for bone infections, right? So as tempting as it may be, and as much as it would be really convenient, they may not have enough penetration. However, there are antibiotics that we know have great penetration into the bone, and the concentrations um, are excellent. So quinolones, right? We know and you'll see most of the studies are done with quinolones. So linezolid and Bactrim actually get about 50% bone concentration. In turn, clindamycin and gets about 40 to 70%. Rifampin, it's almost 100% that, and so is metronidazole. I left something out of here on purpose. What about doxycycline? What do you think about doxy or tetracyclines in general? Any guesses? Why did I leave it out of here? So we don't like to use doxycycline in young kids, right? Or because we know all the issues that it causes with teeth, and so it actually has extremely high bone concentration in the face, but axial bones are actually really low. So you also have to know where the osteomyelitis is. If it's osteo of the jaw, I think it'd be a good drug to use, versus if it's tibia, fibia. So something to also remember. All right. So so this review looked at some of the things that were published previously. So there was a meta-analysis that was published in 2009 that basically evaluated treatment of chronic osteomyelitis, and there was only total 5 trials in that 2009 meta-analysis that looked at IV versus PO, and found that in general there was no difference between the two treatment groups. Also found increased adverse events with IV therapy, and that's something you'll consistently see also in pediatric data as well. Most of these complications associated with line infections or requiring readmission for a subsequent care of the line. Well, what randomized trials were there after that meta-analysis in 2009? So there were 6 studies that compared PO fluoroquinolones to IV and found no difference in cure or in outcomes. And I think as providers, we're all pretty comfortable with using quinolones, right? Orally, just as with IV, there's not much benefit. Another study that was published was a randomized controlled trial looking at IV cloxacillin versus oral Bactrim plus rifampin for MSSA chronic osteo. All the patients had debridement, 20% had prosthetic implants, and the cure rates were very similar. And if you look at those cure rates of almost 90% for Bactrim plus Rif, it's actually pretty consistent whenever you're adding rifampin to your regimen. And so looking specifically at adding rifampin to your regimen for Staph aureus, chronic ostea, or prosthetic joint infections. So you have significantly higher rates of cure if you're going to go ahead and add this to rifampin. So I really do recommend reading this review only because so you as a provider yourself can make a conclusion what is your comfort level and with which antibiotics to treat. Just for the time's sake, I'm not going to go over this one as well, but this was a more recent one published in Journal of Antimicrobial Chemotherapy in 2014, looking specifically at oral antibiotics for staphylococcal bone and joint infections in adults. And it's an excellent overview of every class of antibiotics that have been used and the data behind them. I mean, it's very good, worth reading. It's not short reading, but I think it will definitely allow you to make better decisions as to what you want to treat and when you want to treat it with. All right. So in terms of treatment, like we said, we do not culture sinus tract drainage, right? And with the biggest issue that I want to just point out here, we should not empirically be treating chronic osteo. I mean, how many times have you seen patient comes in with chronic osteo, they're on antibiotics, and then there's a stat ID consult for chronic osteo, and you're like, the patient has had this for 6 weeks. It is not stat. Unless your patient is acutely ill or septic as a result of it. I mean, I don't know if there's any great guidelines that will tell you this, but I think we can all agree on, you know, you have to have a suspicion of an organism that you're going to be treating, right? So if it's vertebral osteo, most likely it's going to be Staph aureus, especially if they're bacteremic with Staph aureus. Um, your extremity osteo will have definitely gram-negative rods. Don't forget our group A strep as well. Sickle cell and in general, your thalassemia patients, that's more of a pediatric issue, but always remember to cover salmonella, right? In these patients, they're prone to salmonella sepsis and then salmonella osteomyelitis. There's actually a separate category for osteomyelitis secondary to nail through tennis shoe, all right? Like separate whole category. I was really interested in that. In general, not an issue. You will not osteomyelitis rate super small with this scenario, less than 2%. Most important thing, make sure you tetanus shot. But if they do develop osteo, what you do want to cover is Pseudomonas. The whole idea being um, that there's Pseudomonas there. All right. Again, say the same thing. So we're kind of going to skip through the slide, but um, we're not going to treat empirically these patients, okay? This is what we've decided. All right, so back to our patient, right? So kind of like you said, our diagnosis, this guy has infective endocarditis, right? Because, he has positive blood culture. He has a 3 out of 6 systolic burden. I'm sure you'll get a TEE to confirm it, but pretty safely say that this guy has osteomyelitis, that he has infective endocarditis. He has also vertebral osteomyelitis that we will find out on our imaging, plus minus an epidural abscess. So if his blood cultures have gram-positive cocci, if you have the PCR biofire, we'll know in an hour what it is, but you can most likely suspect that it's going to be Staph aureus. If you are in Sweden or in Switzerland, where you do not have MRSA, about 5% of all your bugs are MRSA, you're going to be using an anti-MSSA drug, where if you're in a place where 50% of your organisms are MRSA, you're going to rule that out and start with vancomycin. And yes, MRI would be the imaging of choice for this patient. And it's a really difficult patient population only because a lot of them present with chronic back pain. So assessing whether this is worsening of the back pain is important. So with that being said, just talking a little bit about vertebral osteo, right? So now that we have guidelines, it's great. Previously we didn't, and I just want to go back to the studies that actually these guidelines were based on. So this was published in 2014. This was antibiotic treatment for 6 weeks versus 12 weeks in patients with pyogenic vertebral osteomyelitis, and it was a non-inferiority randomized controlled trial. So how many of you in your training have heard you have to do minimum 8 weeks for vertebral osteo or 6 weeks IV and then followed by 6 weeks PO? I think many of us have heard, depending on who you worked with in different areas. So this is kind of nice. This included 71 medical care centers in France, and the inclusion criteria were patients 18 years or older, and it had to be microbiologically confirmed vertebral osteo. Plus, you also had imaging that supported the diagnosis. Patients that were excluded, again, anyone who was not going to survive for the year, for 1 year, because that was their primary endpoint. Anyone who had fungal or mycobacterial infection, because we do know those have to be treated longer. Anyone who has a vertebral implant and a pregnancy or breastfeeding. And so these were the primary outcomes, basically just looking at cured or not cured, and found the 6 weeks regimen had no difference compared to the 12-week regimen. And this was total. So it did not mean that your 6 weeks had to be IV. And we'll see later, a lot of them were transitioned earlier on to orals. This is total regimen duration. This was really exciting. It was first presented ideas at ID Week maybe 2, 3 years back. So it was like, oh my God, it's not so exciting now when you have guidelines. But and here was the secondary. Wait, where am I? Secondary outcomes, looking at back pain and readmissions, and basically the groups were comparable. They found no difference. What was interesting, they also went back to see how long did each group receive IV antibiotics, and did that really make a difference? So there really was not that much of a difference. For the most part, in each of the groups, patients received 2 weeks of IV, and finished off the rest with oral, right? And doing some regression analysis, and the authors found that really things that were associated with failure was not the duration or the type of antibiotic you got. It was older age and having Staph aureus as the causative organism. Okay, so kind of looking at, you don't have to do necessarily 12 weeks or 8 weeks or this was another recent study, again, kind of addressing, do you have to, let's say we can agree on the 6 weeks, right? And we don't do 12 weeks. And then the other question becomes, do we have to keep the patient here for our 6 weeks of IV antibiotics? And so this looked at an early transition from IV to orals after 2 weeks. This was a retrospective study done in Switzerland, which is really nice because they do have a database, a single database that they can all go back, they can go back and review the data. And they excluded patients who had infective endocarditis because you are going to treat with IV antibiotics longer, any spinal implants, and mycobacterial infections. So they had not a huge N, but they did have find 61 patients. Most common organism was Staph aureus, which of 5% was only MRSA. It was, to me at least, it was very interesting that they found 17% of patients had an infection with coag-negative staph, because this is native vertebral osteomyelitis. This is not an organism that you think of causing infections outside of the, like implants or having some hardware. That a significant chunk of patients with actually coag-negative staph. And so 21% of patients were, 21 patients, out of the 61 were eventually switched to oral after 2 weeks of IV. Yes, the oral therapy that they used was a quinolone or quinolone plus RIF. So we know these drugs have excellent penetration to the bone. So they basically also found no difference between the two groups. And what the authors found when they retrospectively looked back, what was the major deciding factor whether the ID physician would transition someone to to orals was the baseline CRP of the patient. So those who presented with higher inflammatory markers at baseline tended to stay on the IV therapy. Those who had lower inflammatory markers at baseline were transitioned earlier. And then, of course, it was fantastic when this was finally came out. It was the latest guidelines from Infectious Disease Society of America, published in CID in September. And they do have tons of recommendations that they go through. Again, just for time's sake, we're not going to go through all of them, only just because there's so many. They tell you when to consider vertebral ostea. So any patient that comes in with new or worsening back or neck pain and any of the following: new fever, also elevated ESR, CRP, or if if they have this new worsening back pain and bloodstream infection or infective endocarditis, particularly with Staph aureus. It was also interesting that the guidelines do recommend considering the diagnosis anyone with fever and new neurologic symptoms, even in the absence of back pain. So again, the recommendations are on the lower end, but they're definitely there. Again, the society outlines nicely who should get empiric antibiotics, and everything that we already talked about. Unless your patient is acutely ill, there's no need to empirically give antibiotics. You need to try to find the causative organism. But the best part was the duration of therapy. The guidelines actually clearly stated that there, for majority of patients being treated for majority of bacterial organisms, total of 6 weeks is sufficient. Um, of course, Brucella is going to get longer treatment. Mycobacterium is going to get longer treatment. The guidelines also go into very nicely detailing when to get follow-up imaging. Should you be getting follow-up imaging? Is it even indicated in the patient? So I think it's definitely worth reading if you haven't read them, just because I go through a lot of nice things. All right. Our next case is a 23-year-old female that presents to the ER. Chief complaint is swelling and pain of her right wrist. She has diffuse arthralgias for the last 2 days, a low-grade fever, and then subsequently developed this new swelling. Her social history is significant for the fact that she has a new boyfriend and she is sexually active. There's a reason why I put that in there. I swear it's not an STD lecture, but there's a reason. All right, so this is bone and joint infection lecture. So, what's your diagnosis, likely organism, and treatment? It is septic arthritis, but what's your most likely organism in this patient? Yeah, so this is gonococcal unless proven otherwise, right? And then the treatment and yeah, yeah. So what? It's ceftriaxone plus azithro, right? The STD guidelines are just recently updated and kind of no longer favor the use of doxycycline, that we can for these infections. But we kind of will go through septic arthritis in general. I'll try to keep us on time. How do we separate out our whether it's bacterial and then or non-bacterial, and then whether it's natural versus prosthetic joint? Again, the spread is similar as to osteo, but what's interesting enough is that hematogenous spread or spread from the bone, to the nearby joint. But so hematogenous spread is the most common. That should say joint, not bone. Let's see. You can also have a spread from bone to joint, but that's actually rare, and bacterial is the most common. Not surprising, right? That the predisposing factors are those that you in patients that already have problems with joints, right? So rheumatoid arthritis, or patients who've gotten any intra-articular injections, IV drug abusers, diabetics, older patients. So for non-gynococcal, it's usually acute, usually monoarticular. You really can have involvement of 2 or 3 joints, but that's going to usually happen in patients who already have predisposing joint problems. So you're, again, patients with rheumatoid arthritis and those who have overwhelming sepsis, and then you seed multiple joints, and as a result. If you see someone with like a septic joint, your sternoclavicular or sternocmandibular, it's an intravenous drug user until proven otherwise. There's very few cases in the literature that are reported in other patient population having a septic joint there. Any guesses as to why? I'll leave you to ponder. No, but I think strictly from a pathophysiology standpoint, that would be the largest first place that it would settle, right? As it gets injected, that's the first place it goes, and um, so yeah. Remember, elderly patients may be afebrile, but that goes for any infection. And in case we forgot our anatomy, here's my friend here. So yeah, there's your clavicle and your sternum. So your sternoclavicular joint would be like right here. Again, you're gonna about 50% of your patients will have positive blood cultures, so that makes it nice. But really, the diagnosis is you have to do the aspiration of the joint. Most of the time, if it's septic arthritis, it's going to be positive unless it's an organism that doesn't grow, right? Or you just recently had antibiotics. And please remember just the false positive on a gram stain that you can have, right? That what happens is you have the precipitation of the crystal violet, right? And the mucin, and then you see gram positive cocci in a gram stain. Really different. Um, how do you differentiate just septic versus non-septic arthritis, whether it's hemorrhagic or inflammatory? Just things to look for. You should have a really elevated white count. You should have really lots of neutrophils in there. You should have really low glucose. Kind of like when you're looking at a CSF, right? Same idea to keep in mind. Um, this is more of a becomes a clinical decision making. What is your patient at risk for? Usually healthy individuals that have no issue. You can think of staph strep will be most common, and then once you start getting into comorbidities and immunosuppression and etc., you're going to start thinking of other things. Also remember where you're practicing. If you're up in New England area, right, you're going to be thinking about our tick-borne infections versus if you're not up there, and it might be different. So also geography does make a difference. And your antimicrobials will be based ultimately on your gram stain that you're going to get back. Oh, what happened there? Well, anyways, gram positive, gram stain, you do Vanc. If it's gram negative, it depends whether you think your patients are at risk for for pseudomonal infections or not. If you're an intravenous drug user or immunosuppressed, I think you should be considered high risk for pseudomonal infections. So again, it all depends on who you ask and how people practice. And how long do you treat? And this I actually do want to hear opinions on because I don't think there's any good data. I could not find any trial comparing durations of treatment and what to treat with. So like the Ayler,
I would average probably 2 to 4 weeks, maybe 3 weeks. So
IVPO.
I prefer IV when possible, but that's just my bias.
No, no. I mean, there is. Okay.
My bias.
So, I mean, I think as
I,
many
I, I
people.
make exceptions, obviously, if it's an IV drug use, the sooner I can get switched to PO, and if I have good PO options, obviously, that's what I'm wanting to do.
I think we need to do a trial out of the VA to see whether when this transit. I mean, because it's such a large system that we can get enough patients, I think it'd be something interesting to look at. But I think most
And with staph aureus, the variolous and the pathogen, maybe
right.
that's the kind of duration.
Yeah, so I think most providers that I've spoken to say minimum 2 weeks IV. Then we'll do 2 to 3 weeks PO unless it's Staph aureus or Pseudomonas, and we try to do all IV unless we have a quinolone that we can. So again, unless, and then comfort level. So I think it's very important to keep in mind that we don't have good data, good guidelines on this. So finishing up with just gynecoccal septic arthritis, it is the most common type of septic arthritis that you're going to see, and it's just one of the manifestation of disseminated gonococcal infection, right? And this usually comes after the rash is gone and the joints, the pain and the myalgias and the arthralgias. So again, and it's usually going to be a single joint, so like large joints, knees, wrists, ankles. So you see a young sexually active patient presenting with a single septic joint, it's uh, Neisseria gonorrhea unless proven otherwise.
Or a veteran patient in 40s, 50s.
That's a young patient.
60s is still game for gonococcal arthritis. I've had a good number already in just 1 year.
Okay, so my bias. Okay, I'm sorry. I do agree.
I think everyone that has multiple sexual partners could argue it.
I think so. It's just an elderly patients. You could be like, well, they have like rheumatoid arthritis. Could this be something else? I mean, I feel like and 40 is young. That's what I'm saying. A young. That's.
Yeah.
It wasn't just a
I
20.
That's why I went to 50s and 60s.
Okay, so something to remember also. Really, if you look in the guidelines for sexually transmitted infections, they do say they recommend for disseminated gonococcal infection that you treat 7 to 14 days. But here you have a joint that's been seeded. I don't know the comfort level really is at 14 days. So I do feel like most providers go out to 21 days. You don't have to do all IV. Once you do have susceptibilities to your oral cephalosporins, I think it's safe to transition your patients. But Dr. Tony, who's not here, could speak better to that. Don't forget to give the azithromycin as well as treat the sex partner or evaluate the most latest sex partners. So we already know what our patient has, right? And so then originally this lecture included this, but then I said, no way, not going to happen. So we'll leave that as a discussion for next time for prosthetic joint infections. And so just to just a summary, bone and joint infections, really a wide spectrum of things and depends on what types of patients you're seeing. Empiric antibiotics only when your patient's acutely ill or it's an acute type of osteo. And you want to select therapy based on your risk factors. And remember, um, you do want to modify treatment based on your culture results, but also look at the patient as a whole, like renal, hepatic function, and the allergies of the patient. And this is our final bonus case, right? You have a 55-year-old male immigrant from Pakistan who presents to the primary care physician. Basically complains of back pain for the last 12 months. He has 15-pound unintentional weight loss and mild weakness of the right leg for the last 2 weeks. His vital signs are all within normal limit. On physical exam, you find that his tender back with deformity at the T6 with a tender and swollen right knee. His x-ray of the T-spine shows interior wedge-shaped collapse of the T6. So what organism is in your differential? Yeah. And what is this syndrome called? Yeah. So we don't see too much of it here locally, but again, remember where your patients are from. That was, I think, something to. So I'll go ahead and take any questions or comments if you have any. And I did fit it in.
What was the literature about ceftriaxone in Staphylococcus?
For MSSA. So there's been some data presented recently, and some stuff has been published using ceftriaxone not in just prosthetic joint, not in just bone and joint infections, but also in deep-seated infections. ID Week this time around had I think 2 or 3 posters and oral abstracts. So I think IDSA and the prosthetic joint infection guidelines could not unanimously recommend the use of ceftriaxone for MSSA prosthetic joint infections. However, I think if you're using it 2 grams twice a day, unfortunately, you lose the once a day option. I think that's where most of the data is. It's not fantastic and it's not across the board. And again, the panel did not unanimously recommend it. There's so few posters, again, even last year, were looking at MSSA bacteremia with ceftriaxone, and only because the hospitals were more or less forced because of budgeting and they couldn't bring the patients back for other IV antibiotics and to some of the more indigent patients. And I think if you have other options, again, for skin, soft tissue, mixed infections where you want to cover gram negatives, I think it's okay. I don't know necessarily that I would feel okay with a deep-seated infection just yet, based on the data that's available. Especially we like ceftriaxone because of its once-a-day dosing, but most of these, yes, but most of these infections would have gotten twice-a-day dosing anyways. So again, skin, soft tissue, I think it's fine. I think vertebral osteomyelitis, I don't know if I feel comfortable